Assalamu alaikum wa rahmatullahi wa barakatuh. This is a case where working with a partial denture. We're going to do a cast alloy RPD, which is chrome cobalt. Okay, so it's a chrome cobalt RPD. We are still in the initial evaluation. These are the study casts that we're going to use, and we are still evaluating the case. One of the noticed thing that the gingival health is a little bit compromised. You can see a lot of recession here. Okay, this is a problem because we in chrome cobalt, as we know, chrome cobalt should be a definitive treatment. So if you are talking about phases of treatment, the initial phase, emergencies, the treatment, preparations, stabilization phase, and interim restorations, and then the final. This is where chrome cobalt comes. Okay, so we are in the fourth stage of treatment planning. Okay, why? Because the alloy, once we cast it, suppose there is some recession afterwards, we will lose the beneficial contacts with the soft tissue. Okay, so if I'm going to do scaling for this case, and it might even need root planing. Okay, the gingival level will not stay the same. So suppose I'm doing some metal connection, minor connector with a guiding plate, for example, a guiding plate. After root planing, this will not stay in the same position, so I'll lose this contact with the metal. Okay, favorable relation with the margin and gingiva of the metal. The metal will be going over the margin and gingiva, but if this gingiva resolves after the edema resolves after the root planing, what will happen? You will make this gap larger beneath the metal or the alloy, which we designed. This becomes accumulating fruit and plaque. Okay, so chrome cobalt, when it comes close to the soft tissue, it is a definitive treatment. Okay, we don't want the tissue changing a lot after it. Okay, also we need to make the patient needs to maintain their oral hygiene. So I also, once more, I don't want continuous periodontal lesions and progression and bone resorption and so on. What else do we notice? We notice also there is something here. And asking about this, the student is not aware of it, that it might be a carious lesion or it might be a defective filling. I'm not sure from this view. I need to go back intraorally and check it. But what does this affect us? Once more, this is a lesion that could contagious to others. Definitely, always there is a rule. Wherever you have caries, you have the possibility of being contagious in cariology, microbiology, because these are matured enough. The microflora have matured into the acidic producing and caries producing lesions. So this is cariogenic to the other teeth. Okay, so we have to resolve any carious lesion. We should not place chrome cobalt on them. Also, there is another angle for this, which is where am I going to place my rests? So this is in the area where possibly I'm going to use a rest. So either I plan a large restoration correctly with the correct depth and width to accommodate a rest, and we know rests are not allowed to be put on small restorations. You should have around a margin of 2 millimeters around the rest body. So it should be a huge lesion, restoration, and it might go to an inlay or onlay, for example. Okay, or a surveyed crown if it was larger. Okay, so this will shift my design. So I should not design unless I have this. Or another option is having this treated and using a rest distally. So this is also another that I should resolve all carious lesions for this reason. So it's one, because it's contagious. Second, because there should be a restoration. The restoration will dictate my application of components. Even a guide plate, how am I going to place it? Am I going to place it after the metal framework? No, because the next visit after this is your preparation and the tooth, a secondary cast, and then metal try-in. So metal should be, the teeth morphologies should be complete, free of any disease before going to chrome cobalt. Okay, there is also this case, if you notice here, I found that this margin of this restoration, I could see them here on the stone. So I need to evaluate it clinically. There's like ditching on the surface. Do you see this margin? Okay, if this was an amalgam, I need to replace it. Okay, if there is any secondary caries, I need to replace it. I could see it's bulky here, so I need to check the caries beneath the root. Okay, beneath the filling on the root surface. So there might be some lesions here because I see it's overhanging. See how it's overhanging? I could notice the overhanging. So all of these should be resolved before going into the crown procedure. Also, sometimes I see this. Do you see this irregular surface? What is this? Why is it very irregular? It might be calculus. It might be a defective. I see. It seems for me that there is a defective filling on this surface. This is how it seems. I could see a margin here. I could see something flowing on this tooth, and I could see something here. So this is a defective margin, okay, of restoration. This also should be resolved. What do I see here? I see debris. This might be irregularities with the impression, or it could be calculus, actual calculus. And usually these patients have these problems. So what are you going to do before deciding on this cast? We're going to ask you to re-evaluate this filling. If it was favorable and x-ray and no caries and so on, you could simply polish it and remove the ditching of the margins and just re-polish it, okay, with copious amount of water. But if we don't, if otherwise, we might be thinking about crowning this tooth, removing of the filling, evaluation of any remaining remnant caries, secondary caries, and maybe survey the crown here. Okay, this tooth. Inspection of this. What is it? Is it a broken filling? Is it a caries? We have to also treat it. We might shift our design to a distal rest, and I'm going to check this inside the patient's mouth. And I'm going to treat it and clean it. Okay, so to work with it. Now, once we finalize these, we are ready to do our design. Thank you.